Thank you, Chairs. It's a great pleasure for me to be with you today, albeit virtually. What I'll do in the next 20-25 minutes is to discuss the new cardio-renal metabolic frontiers with new drugs. This is my potential conflict of interest. Now, when we talk about cardio-renal metabolic risk, we have to understand that usually we are used to look at the absolute cardiovascular risk as moderate, high, and very high. But the highest level of risk of the absolute cardiovascular events, let's say in a patient after an MI, then it's much, much less of the non-absolute cardiovascular risk that it occurs in patients with CKD, especially when they are stage 3 or stage 5. See, they have an increased risk of both cardiovascular events, but also of developing LVH, arrhythmias, sudden cardiac death, arterial calcification and valve calcifications, and also the hemorrhagic stroke. So the overall cardiovascular risk of patients with renal disease is significantly increased. And you see also the overall risk of heart failure increases significantly as the renal failure progresses. Now, undoubtedly, whenever we look at our patients with heart failure, with cardiovascular disease, we see that there is a progressive decline in eGFR. This is something that occurs in all patients with cardiovascular disease. These are data from the EMPEROR reduced in the placebo arm, so that tells you the natural history of patients with cardiovascular disease with and without CKD. So the decline in renal function occurs also in patients without abnormal renal function at baseline. And it's also important to understand that when patients have worsening renal failure, and they also come in with an acute heart failure, you see they have a significantly worse prognosis. These were patients collected by Marcometra, and you see there were patients with worsening heart failure, no congested, where did much worse than those with worsening heart failure and congested, and associated with renal dysfunction. Now, what can we do for renal dysfunction? I mean, for the past 30 years, there's been we've had only two classes of drugs that have demonstrated some efficacy in renal failure. You see the ACE inhibitors and the ARBs. They've demonstrated a significant reduction in renal endpoints, not much in the overall composite endpoint of cardiovascular events. But then we had the evidence that the ACE-ARB combination doesn't work. The direct renin inhibitors like aliskerin do not work, and other interventions like sulodexide and bardoxolone, they as an anti-inflammatory did not work. And then I think everything changed in 2008. I mean, it started with concerns on the safety of the diabetic medications that were associated with an increased risk of cardiovascular events. And for this reason, the EMEA and the FDA issued the regulatory obligation for all new anti-diabetic medications to undergo a cardiovascular safety trial to start with. And so we had the proliferation of studies with the SGLT2 inhibitors, with the GLP-1 receptor agonist, with the DPP-4 inhibitors, and these have led to very important surprises, because rather than showing safety, they showed efficacy, and especially the EMPEROR outcome, the CANVAS and the DECLARE, they demonstrated with empagliflozin, canagliflozin, and dapagliflozin a reduction in the primary outcome, and this was mostly led by the reduction in heart failure. These trials were different because the EMPEROR outcome, of course, had patients who had increased elevated absolute cardiovascular risk. The CANVAS included more than nearly 65% of patients with proven cardiovascular risk, whilst DECLARE had a more balanced occurrence of cardiovascular risk. So you can see that the three trials together, they take the whole spectrum of patients with increased cardiovascular risk, and they've demonstrated that the in those patients with the presence of an absolute cardiovascular risk, there was a significant reduction with the SGLT2 inhibitors of both the major cardiovascular endpoints and the heart failure hospitalizations in patients with type 2 diabetes. But together with that, there was something that didn't come immediately intuitive, but came up on very, very clearly with the three trials together. You see that both in the CLARE, CANVAS, but also in EMPEREG, patients were receiving empagliflozin, canagliflozin, or dapagliflozin had a significant reduction on the event rate, on the cardiovascular, on the renal endpoints, and therefore suggested that besides the beneficial effect on cardiovascular outcomes, there were a very important effect on renal protection. Then, therefore, with the SGLT2 inhibitors, we have trials in different populations, patients with type 2 diabetes who are at risk of cardiovascular disease, patients with heart failure, chronic kidney disease, and these 13 trials included more than 90,000 patients. Now, the analysis of all these trials demonstrated that overall there is the SGLT2 inhibitors reduce cardiovascular risk in all patients with both with diabetes and non-diabetes. But if you look more carefully, the effect on CKD is much more pronounced, in those with diabetes, whilst in those without diabetes, this effect is not that significant. Therefore, that brings us to the cardio-renal metabolic disease. So patients with increased cardiovascular risk, with diabetes or prediabetes, or obesity, and patients with a decline in renal function, they benefit from the SGLT2 inhibitors as they reduce significantly the progression of CKD. So we had three positive trials, homogeneous results across the subgroups that demonstrate a clear prevention of heart failure hospitalizations, but also renal outcomes. Then we had the trials in heart failure, and the EMPEROR Reduce demonstrated the efficacy of empagliflozin in reducing in improving events in patients with heart failure, but also demonstrated that patients receiving empagliflozin had a significant reduction in the occurrence of the composite renal endpoint that was reduced by 50%. So it was very significant reduction. The same was shown with dapagliflozin in the DAPA-HF trial. Then there were, based on these results, we had trials that were specifically designed to look at the cardiorenal outcomes in patients with CKD. And the DAPA-CKD included 4,000 patients that were randomized to dapagliflozin or placebo. These were patients with diabetes mellitus, with CKD, with and without diabetes, and with and without heart failure. And the study demonstrated a 39% reduction in the composite endpoint of decline in eGFR, end-stage renal disease, or cardiovascular death. You see that there was a very significant 40% reduction in renal events and cardiovascular events. That was led mostly by 44% in the composite renal outcome, but that also was accompanied by a 30% relative risk reduction in cardiovascular death or heart failure hospitalizations, and a 30% of reduced risk in mortality. And indeed, the trial was so positive that it was stopped early by the DSMB because it was because of the overwhelming benefit. Based on these trials and on this data, we, with the Heart Failure Association and the International Society of Nephrology, developed this heat map, where basically show where the SGLT2 inhibitors in patients with CKD are indicated. You see, the indication is to start in patients up to an eGFR of 15, down to an eGFR of 15, with normal or moderately increased albuminuria, or even in those with a severe increased albuminuria. So there is a vast proportion of patients that needs to be treated with CKD that can be treated with the SGLT2 inhibitors for the prevention of future renal and cardiovascular events. Now, alongside the benefit that has been demonstrated by the SGLT2 inhibitors, the GLP-1 receptor agonist demonstrated a reduction in events with both in the leader and sustain, and in all the other studies that followed with liraglutide and semaglutide. But also the semaglutide was tested in the sustain 6 and pioneer 6, and together they've included more than 6,500 patients. And the pooled analysis of the two trials that looked at the semaglutide versus placebo demonstrated a benefit of semaglutide versus compared to placebo in reducing the progression of each GFR decline. So that was the first evidence that also the GLP-1 receptor agonists may be effective, are effective in slowing the progression of renal disease. And if you see with the GLP-1 receptor agonist, looking at the data, you can clearly see that in all patients there was a protection from semaglutide compared to placebo, and that was also something that occurred with liraglutide. But focusing more on semaglutide, you can see that this effect was the reduction in the progression of kidney disease was demonstrated in the overall population, so in all the population with an eGFR less than 60, and but it was very evident in that population with an eGFR between 30 and 60. In these patients, there was a very significant reduction in events between the two groups, and you can see how with the renal function remained stable in patients receiving semaglutide, where it declined in the placebo group. In patients with, let's say, with more preserved renal function, with more than 60 millimeters per minute, you see that there is a less of a decline, less of an effect, also because the rate of decline is much less, and but it's still the positive effect. Now we know that the GLP-1 receptor agonists are effective. We have recently the data from the SELECT trial that demonstrated the overall cardio-renal metabolic benefit of semaglutide. The SELECT was a study in patients with obesity and elevated cardiovascular risk, and demonstrated a reduction in cardiovascular death, non-fatal MI, and non-fatal stroke with semaglutide. Also, the SELECT study demonstrated that reduction in death from all causes, heart failure composite endpoint, and death from all causes. And what is important is also that they demonstrated a significant reduction in major cardiovascular events and heart failure composite event in those patients who had heart failure at baseline. Now, going towards the end of my talk, it's something that we need to touch upon is also the MRAs. MRAs, we know that the aldosterone has all sorts of negative effects on vessels, heart, and kidney, and the increase in aldosterone is negative for the progression of cardiovascular disease, kidney disease, and is something that's very frequent in patients with diabetes. And with more recently, we had very specific trials that were conducted in patients with CKD and diabetes. These were the two studies with a new non-steroidal MRA, the finerenone. Patients were randomized to receive either finerenone or placebo in two big trials. One was the Figaro-DKD and the other one was Fidelio. They had a slightly different primary composite endpoint, and they've included 12,000 patients with diabetes and cardiovascular disease and renal disease. You see that then we put together this analysis. This is the Fidelity pooled analysis, where we put together the Figaro and Fidelio, looked at the cardiovascular composite endpoints of time to cardiovascular death, non-fatal MI, non-fatal stroke, or hospitalizations for heart failure. Now, if you look at the population, and you remember the heat map I showed you earlier, for patients with from the ISN and the HFA, you see that the figure takes those patients with increased albuminuria and moderate to severe eGFR compromise. The Fidelio DKD included patients who similar patients but extended to patients with more severely increased albuminuria. So overall, Fidelio, the fidelity pooled analysis looks at all these patients that we've also included in the ISN HFA heat map. Looking at the patient characteristics, there were 50% almost were the history of cardiovascular disease and heart failure. And the Figaro and the Fidelio were both positive, demonstrating a reduction in the primary endpoint, so cardiovascular death, non-fatal MI or stroke, and for Fidelio, cardiovascular death, non-fatal MI and stroke. But putting together these trials into the fidelity analysis, so taking patients with cardiovascular disease, diabetes, and more extended definition of CKD, then we see that the finerenone was effective in reducing by 14% the time to cardiovascular death, non-fatal MI, non-fatal stroke, or heart failure hospitalization. So there was an effect of finerenone in these patients. This effect was mostly related to reduction in heart failure hospitalizations and cardiovascular death, less of an effect on stroke. But what came also very significant was that in the fidelity, the finerenone reduced significantly the composite endpoint of a sustained decrease in eGFR from baseline or renal day. So in conclusion, patients with cardiovascular, renal, and metabolic disease are at increased risk of mortality from cardiovascular and non-cardiovascular causes. The cardiovascular mortality is increased in patients with the metabolic disease and in those with renal disease. So when they coexist, that causes patients those patients should be considered patients of very high risk. Now, we know that patients with heart failure have a progressive deterioration as patients with cardiovascular disease of their renal function, and that worsens with worsening left ventricular function. Now, the new therapy for the cardio-renal metabolic disease, they include the SGLT2 inhibitors, the GLP-1 receptor agonist, and the non-steroidal MRA. They are been shown to be effective in reducing the cardio-renal endpoints and mortality, and they should be implemented as soon as possible in those patients who may benefit, according to what I showed you in the heat map, in order to reduce the progression of the disease. I'll stop here, and I'll be more than happy to take your questions.